All right, now we're going to go ahead and go to the poisoning chapter. Poisonings count for is the fourth most common cause of accidents in children. And the majority of poisonings occur at two different age ranges. Generally, there's a big peak under 5 years of age, particularly 1, 2, 3 years of age. Children are getting to everything, put things into their mouths, whatever. And then in teenage years, adolescence, the rate of poisoning rises again. You need to consider that those poisonings are intentional. Okay? Obviously, a 15-year-old knows what they're doing when they take a bottle of something, of pills, but a 2-year-old might not. So any poisoning over the age of 5 years should be considered intentional or non-accidental. Parents gave it to them, somebody did something to them. Okay? So it's non-accidental over 5 years of age. You need to remember that when you're answering a question and you're getting more history. Is this child abuse or not? Well, if it's a 1.5-year-old that got into something in the kitchen, that's probably just an accident. But if it's a 7-year-old, then something else is going on. It's either the child wanted to do it on its own or somebody made him do it. The majority of poisonings occur in the home. And the most common place is in the kitchen and in the bathroom. And when it comes to poisoning, we talk a lot about anticipatory guidance. Pediatricians spend a lot of time doing anticipatory guidance, talking about safety, using seat belts, things like that. By the way, when should a child go into a car seat? As soon as it's born, on the way home from the hospital, right? So who said that? I said that. Who said that? He said it. Didn't you get one yesterday? Oh, you got it yesterday. Okay. All right. So you should go into a car seat when you're born. And we'll talk a little bit more about it when we talk about accidents and emergencies. So usually poisonings occur when normal routine is disrupted. We talk to parents all the time about do this, lock up things, put things out of reach and all. But poisonings still occur. And it's usually when your normal routine is disrupted. When does that happen? Well, you go on vacation, for example. Or you're visiting grandma or whatever, and they have not, quote-unquote, child-proofed their house, and the child gets into something. And that's when a lot of the times that you see these poisonings occurring. Also, when you've moved, things are in boxes, things haven't been put away yet, you haven't put the locks on the cabinets, that's when you can see poisonings. Child safety caps are very good for prevention of poisoning. However, child safety caps can give you a false sense of security. Sometimes I think at home I'm the only one that can't open a child safety cap. My kids can open them and I can't. So just because there has a child safety cap on it, don't think that the child can't get into it. I always say that the child is like a little burglar. If you give them enough time, they will break into the cabinet or the medicine or whatever. And the whole idea is to make it hard for them to get into things so that A, they get tired and go away, find something else to do, or B, you catch them in the act. So child safety caps are good. Keeping medicines up out of reach in locked cabinets is also good prevention. All poisons should be properly labeled. Many times you will get something and put it into a different container that might be more convenient. Well, that needs to be labeled so you know exactly what it is if the child gets into it. Everything should be up and out of reach, and it should be in locked cabinets if possible. Medications should not be taken in front of children. So if you have to take something for your blood pressure or for your thyroid or you have a headache, whatever, you should not be taking medications in front of the child because that sends the message to the child that, well, mom and dad do this, so I'm going to do this too when they get into something, be it a medicine or something else. They'll put it into their mouths because they've seen you do it. Every so often, you should go into your medicine cabinet and just get rid of all the stuff that's expired. And by getting rid of it, you should just flush it down the toilet. Don't just throw it away in the garbage because they can pick it out of the garbage too. Okay? So these are things that you can do to prevent poisonings at home. You should always have poison control number at home. And as part of our anticipatory guidance, we tell parents you should have a poison control number at home, and we always tell them to put the number on the baby's where they carry the bottles and all that stuff, all right? Because that, and that bag, because that bag goes wherever the baby goes, and the diaper bag and all, that goes where the baby goes, so you always have the poison control number handy. And we also recommend having Ipecac at home. Ipecac is an emetic. However, we always recommend that you call poison control first before you induce emesis. Some first aid tips. Again, always call poison control first. Ipecac may be used if it's recommended, so that's why it's nice to have at home. Usually induces emesis within 10 to 15 minutes of taking it. If the poison is something that is inhaled, then the patient should be removed from the source. If the poisoning is something that is absorbed through the skin, and we'll talk about an example in a little while, if it is absorbed through the skin, you should take that child's clothing off and wash them off so that you prevent further absorption. So these are basic things that you can do at home. If the patient has swallowed the poison, induce the vomiting if it's appropriate, and go to the hospital. And if it's something that gets into the eye, you should just flush the eye out with lots of water. In the actual emergency department, you always should worry about ABCs. So we talked about resuscitation yesterday, and we should worry about ABCs. So always take care of airway, breathing, and circulation. You do a very fast, focused exam, and you get a quick history, and once the patient is stabilized, then you can go out and get more history. You need to know how many pills did you think the baby took, or how many pills were in the container, how many are missing now, and that way you can figure out how many pills were taken. You can ask them to bring in the container. You can ask them, timing of things. And one thing that you should remember when you make a diagnosis of an ingestion or a poisoning is when you're reading a test question, or in real life, a bizarre constellation of symptoms. So if there's a lot of things that just really don't seem to make a lot of sense, and you'll see it when we discuss what these different poisons can do, you should be thinking of poisonings, because you can think of, congestive heart failure, and you can say, okay, it gives you this, this, and this, and this all seems to make sense. But when you start throwing in other things, you go, wow, that doesn't make sense. You should be thinking of possible poisonings or ingestions. There are certain things, once you've done your ABCs, that you can do, and those include preventing absorption. Preventing absorption of the poison can be done by causing emesis, as I've mentioned already. Usually it's best in the first 4 hours. You can also do gastric lavage. You can give activated charcoal, and you can give cathartics. Diuresis may help in certain ingestions. Gastric lavage should be given if the patient is not vomiting. If the patient is actively vomiting, you don't need to give gastric lavage. If the patient has a depressed gag reflex or decreased level of consciousness, then you don't want to stimulate vomiting because they can aspirate. In that case, then gastric lavage may be indicated. Gastric lavage is not indicated for any corrosives. It'll make things worse. So you need to know the indications for gastric lavage. If the patient is comatose, has a depressed gag reflex, and you're considering gastric lavage, you should get an airway first to, again, prevent aspiration. When you do gastric lavage, you should use the largest tube possible that fits into the stomach, through the nose, mouth, and into the stomach, because you don't want like pill fragments to clog it up. So you choose the biggest tube you can to put it into the stomach. Activated charcoal. Really, there's no contraindications. It doesn't help for everything, but at least it won't hurt. However, you don't want to give activated charcoal if you just gave Ipecac, for example, as an emetic. So if the patient just took some Ipecac and you give activated charcoal, the activated charcoal will absorb the Ipecac and you won't get the emesis that you wanted. So you don't want to give one and then the other. Usually it requires a nasogastric or an orogastric tube because this stuff tastes lousy and nobody's going to drink that. Activated charcoal does not really help against certain drugs, and they're listed there. Cyanides, metals, sodium, potassium, chloride, acids, and bases. It will not help. Doesn't hurt, but it won't help you. Cathartics. Cathartics will help move the stuff along so you don't absorb it through the intestinal wall. Cathartics magnesium cathartics should not be used if the patient is in renal failure. And another way of eliminating the drug is through diuresis, hemoperfusion, dialysis. So these are all ways to decrease your levels of the medication. Now, when we talk about dialysis and hemoperfusion, those are like last gasp measures usually, where nothing else is helping and the patient is getting worse. The majority of poisonings require good supportive care. There are few real antidotes, and we'll discuss some of them as we go along the chapter, but there are really very few antidotes for most of the poisonings. And the key is good supportive care, taking care of your A, B, C's. We're going to talk now about some of the specific poisonings, and we start off with acetaminophen. A 3-year-old was playing doctor with his 4-year-old sister. The sister told him that he was very ill and prescribed 25 acetaminophen tablets, which the younger child ingested. Good patient, huh? Another case you might get is of the 16-year-old who decided to take a bunch of acetaminophen after having an argument with her mother or breaking up with her boyfriend or something like that. And now the patient's complaining of some nausea and vomiting. Okay, so that's another way that it might present with acetaminophen. And of course, if everybody takes acetaminophen because 4 out of 5 doctors prescribe it, say it's safe, right? So it's not safe. In children, it really doesn't cause as much hepatotoxicity as it does in adults. So this little, I told him, this little boy is probably going to be okay, but there are certain things that we need to do for him. Acetaminophen is used for analgesia and as an antipyretic. It is metabolized in the liver. It will cause liver damage if taken in a big enough dose, although not as common in children. You have there the toxic dose. In children less than 12 years of age, the toxic dose of acetaminophen is 150 milligrams per kilogram. Now, when you're reading this question, you really don't know how much the child took because they're not giving you the weight and they're not telling you how many tablets he took. But in another question, it might say the patient took 325 milligram tablets, and if they give his weight, then you can figure out how big a dose that was, if it's really bad or not. Usually the presentation of acetaminophen ingestion or poisoning goes through certain phases, and you can pretty much time them. So stage 1 is the first 24 hours after ingestion. That's when the patients will have nausea, vomiting, and diaphoresis. They don't have a lot of symptoms then, but usually in an older child, they start feeling sick, and then they might say that they took something. At this time, since we say that it's hepatotoxic, this is a good time to get your liver function tests because they will be normal still. So the patient comes in and has these findings, and you suspect acetaminophen, or they're telling you that's acetaminophen, they might ask, what labs do you get? So what labs do you get? Well, everybody gets a CBC because everybody gets one. Liver function. So what liver function test do you want? Okay, liver enzymes, so transaminases. Here's one for you, transaminases. Okay, so you want coagulation studies. Who said that back there? Okay, you. Okay, so you want coagulation studies because transaminases are helpful, but later on, and you need to remember this forever, it doesn't have to necessarily to do with acetaminophen, but you have to know this for liver problems. Many times, your liver enzymes are coming down, your transaminases are coming down, and I could argue that the patient is getting worse. Okay? And I can argue that the patient is getting worse because the coagulation studies are going up, and because what else is going up? The bilirubin. Who said bilirubin? Oh, man, in the back. Okay. So the bilirubin is getting worse, or the albumin is getting worse. Why is that happening? Because now your liver is so shot that you don't have any more transaminases. You've had so much necrosis that there's no more transaminases to liberate. So you also need to get, besides LFTs, everybody calls them, the transaminases, you need to get the albumin, the bilirubin, and the coagulation studies. Okay? What else do you need to get? Not in this particular patient, but if I tell you, so you get a CBC, you got your liver functions and all, and I tell you that's a 15-year-old, 16-year-old girl. Pregnancy test. Who said that? Okay. All right, you always get a pregnancy test. So if they give you a bunch of tests to examine, let's say it's a teenager that took a bunch of stuff, a teenage girl, always look for a pregnancy test as part of what you're going to order. Okay? That's just a fact of life. So in stage 1, you are going to have normal liver function tests. And that's when you get them. So that's your quote-unquote baseline. Stage 2 occurs in the next 24 to 48 hours. And at that point, the patient starts to actually look better. They feel better. They don't have that so much nausea or vomiting. They're actually getting better. However, if the patient is going to have liver problems, that's when you'll probably see changes in those liver enzymes and your PT and your bilirubins and stuff. Okay? So you get them when they first come in, and you get them at about 24 hours after the ingestion, and probably daily for the next couple of days. But if the patient is going to have liver problems, that's when you'll first see them in that second stage, even though clinically they look better. The third stage occurs at around 72 to 96 hours after ingestion, and that's when the patient will have a peak in their liver abnormalities. And that's when you're going to find out whether this patient is going to, recover, or if the liver is going to get worse. And at stage 4 is when the liver is actually starting to get better. The majority of children, like I said, do not have liver problems or long-term liver problems. However, complications do include liver failure, and sometimes patients have to go out and find themselves a new liver. Well, we find it for them. So they may need liver transplantation. Okay? Okay, so what do we do for these patients besides ABC? Well, the first thing you need to do when you get your tests is you also need to order an acetaminophen level. And it's very important. Usually, acetaminophen peaks at about 4 hours. So if you get, that's why we have this nomogram the way it is, okay? And it's at 4 hours is the peak, and after that it'll keep going down. And you need to know what the level is at 4 hours or after, because that lets you know about treating the patient. We always take care of airway, breathing, circulation, but for acetaminophen, we do have an antidote, and the antidote is N-acetylcysteine. And you need to know whether to give it or not. So that's why you need to know the level. So the patient comes in, and we have this. And I won't give you numbers here, but what you need to know is if the level falls in this range down here, below that line, this is what we call the area of no hepatotoxicity. You're okay. And it doesn't matter what time. If the patient comes in, let's say at 6 hours and the level is down here, or at 8 hours and the level is here, or at 20 hours and the level is here, this is probably what they call an area of no hepatotoxicity. If the level falls in between these two lines, and you have levels in your notes, it'll talk about it, but if it falls in between these two lines, then that's what we call the area of probable hepatotoxicity. I'm sorry, possible hepatotoxicity. This is possible hepatotoxicity. And if the level falls above this line, it doesn't matter the time, then that is an area of probable hepatotoxicity. So if the patient's level falls down here, you don't have to give the N-acetylcysteine. But if it falls in these two, you should. What's so important? Why can't we just give it to everybody? Well, you got to give a lot of doses of N-acetylcysteine. You give a loading dose, and then you give a dose every 4 hours for 16 more doses. And generally, the patient will not drink it. It has to be given through an NG, because it really tastes lousy and it smells like rotten eggs. It's terrible. I know of one patient, this poor girl, really regretted what she did after taking her acetaminophen, and she would, rather than have the NG in there, which was gagging her, she would take it like shots of liquor or something. She would just drink it down. Okay? But most of the time, you have to give it through an NG, and you have to give 17 total doses. Once you start giving the N-acetylcysteine, it doesn't matter what the levels are. You don't have to get any more levels, because the level will drop. So that's not going to change your treatment. It's not like you give a dose of the stuff and the level drops down to here, you can stop giving it. No. And that's why you need to know the level before you start. Because once you start, subsequent levels don't help you. And you're pretty much committed to giving the full course of the whole 17 doses. So that's why you need to know the nomogram. Activated charcoal can be used because many times the patient has taken something else, so you might absorb that, okay? But the most important thing is get a level and then decide where it falls. If the acetaminophen level is greater than 150, you should treat. And N-acetylcysteine is best given within 8 hours of ingestion. It can be given later, but its effect's much better if it's given within 8 hours of ingestion. And you follow your liver functions. Okay, so that's acetaminophen. The next one is alcohol. A high school senior arrives in the emergency center, immobilized on a backboard with cervical spine collar in place after a motor vehicle accident. The patient was a restrained passenger. That's strange, right? Most adolescents don't want to wear seatbelts, but the patient was a restrained passenger in the back seat passenger side. He states that he and the 5 other teens in the motor vehicle had just left the party when their car was struck. The smell of alcohol is present on physical examination. So alcohol can be used in a lot of things and comes in different forms. You do need to know that the alcohol content, for example, of a 12-ounce beer equals the alcohol content of about a 9-ounce glass of wine, which equals the alcohol content of a shot of hard liquor, which is about 1.5 ounces. They all have the same amount of alcohol in them. Alcohol use is seen a lot in adolescents. It can affect their normal function. Yeah, they lose their parachute reflex, remember? And threaten society, because if they're driving, not only do they get in a wreck, but the people in the other car, the person who's walking down the road minding their own business or riding their bike, and they get hit by the drunk driver. So not only affects them, it affects other people. Affects the families. The level, the alcohol level, is what influences the effect, or what you're going to see, how the patient will present. And the alcohol level depends on the quantity of alcohol ingested, the size of the patient, and whether food was ingested or not. And to some extent, so for example, a small person versus a big person, the big person should be able to tolerate a higher amount of alcohol ingestion. It also depends on tolerance. Okay? There are some people who just tolerate it better because they've been drinking longer. Bigger quantities longer, okay? Some people don't get up in the morning unless their alcohol level is a certain, over 110 or whatever. They can't function. So tolerance has something to do with it too. Most states, and it depends. What is it in New York? What's the legal? Is it 0.08? 0.1? Point what? 0.08. Not 0.8. That's a lot. Depends on your tolerance, okay? All right, so here it's most states are going to 0.08, but some states are still 0.1, and that means that you're legally drunk. Now, you can argue it's not affecting you or not. That's not the point. The point is that's the legal level for being drunk, 0.08 to 0.1, or 100 milligrams per deciliter, or 80 milligrams per deciliter. The reason being that even from 50 to 150, you can have some effects, and you have a list of them there. At 50 to 150, the patient can be uncoordinated and have blurred vision and a slow reaction time, even though the patient may not think so. At 150 to 300, you'll have visual impairment, staggering, and slurred speech. Levels of 300 to 500 will produce stupor, hypoglycemia, and coma. And a level of greater than 500 is fatal if the patient has no tolerance, particularly if you just take a lot all at once. I remember in training, we had a 12-year-old brought in who was brought in as a trauma because the brothers found him on the floor and he had fallen off the bed. They brought him in and he was comatose. He was intubated and they did a CT scan and it was normal. So they called the pediatric ICU team. And the first thing we asked was, they said he had an acidosis on his blood gas and We said, well, did you guys get an alcohol level? He goes, that's pending. Well, by the time we got down to see this child, the blood alcohol level had come back, and it was like 320. Okay? And when he finally came to, he told the story, he was sitting in his bedroom, and he just chugged a bottle of rum. So his level went up fast, and he was lucky that he stayed alive, enough to at least fall off the bed and alert the rest of the family. So it does have something to do with tolerance. Those are the symptoms that you'll see with different levels. How do you diagnose this? Well, you're going to suspect it. Generally, they do have a little aroma to them, and you should get an alcohol level, and a blood sugar is very important because they can have hypoglycemia, and that's something that you do need to treat. The treatment, there is no specific antidote. It's basically supportive treatment. You do treat hypoglycemia and acidosis. This child presented with a metabolic acidosis. Artificial ventilation may be necessary. This child got it. Alcohol, don't forget, is absorbed by, remember your biochemistry? Michaelis-Menten kinetics? Yeah, gosh, it's haunting me again. So it's zero-order kinetics. What does that mean? It means it is going to be constantly metabolized at the same rate regardless. So it just goes away at the same rate. So basically, you're going to just do supportive care. Dialysis or activated charcoal, you can try activated charcoal because they may have gotten into something else, but it's not really going to help for the alcohol itself. And if you have high blood alcohol levels and nothing is helping, you may consider dialysis. But that's, again, the last gasp measure. Amphetamines. The guidance counselor refers a 10th grade student to the school nurse for weight loss, insomnia, and depression. So amphetamines are stimulants. So why is this guy depressed, right? He's coming down off them. And methamphetamine is now very popular. And we're not even going to get into all the names that they call these things because it's like, I can't keep up with them. Patients will have either acute or chronic toxicity from amphetamines. Acute toxicity includes diarrhea, palpitations, arrhythmias, syncope, hyperpyrexia, hyperreflexia, and they can actually have seizures and become comatose. Chronic toxicity, which it sounds like is what this child has, is because of tolerance, and symptoms include restlessness, nervousness, depression, insomnia, suicidal behavior. They have weight loss. So this child, in this particular question, probably has chronic. And how do you diagnose it? You can do a urine drug screening test, and you will find amphetamines in the urine. Treatment may require hospitalization, particularly acute toxicity. You'll need supportive therapy, meaning attention to airway, breathing, circulation. There is no antidote. Cooling blankets can be used for the hyperthermia. You may need to sedate the patient, but there is no antidote. Okay, aspirin or salicylates. And the reason we throw in salicylates is because there are other products that have salicylates in them. A teenage girl is brought by ambulance to the emergency center because her mother found her ingesting a bottle of aspirin. The patient states that she wants to die as her boyfriend has decided to date someone else. Okay? No comment. Aspirin is used as an analgesic and an antipyretic, but also remember that there are other components, other medications that have salicylates in them, and one of them is oil of wintergreen, okay, or some of these salves that you put in, for when you have you've been exercising and your legs hurt and you just rub that stuff. Yeah, I don't want to use brand names, so I'm not saying that, okay, but you know what I'm talking about. All those creams that you use, they sometimes have salicylates in them, okay. So remember, it's not just the aspirin tablet. Salicylates are probably the most common cause of drug poisoning in the United States, and that's not just in children. That's why it's the most common, okay? Because a lot of old people are taking aspirin for their arthritis or whatever, and grandma's not working like it used to. not lasting the 4 hours, so they take a little bit earlier, or they take a little bit more, and over a week's period of time, now they can't hear, they hear a ringing in their ears and stuff, and so they're kind of getting a chronic ingestion there. So it's because a lot of people use it. It's not just in pediatrics. So aspirin is the most common drug poisoning in the United States because other people are using it, not just children. So what do salicylates do? They uncouple oxidative phosphorylation, increase your metabolic rate, and they cause tachypnea, tachycardia, fever, and hypoglycemia. So again, you try to put those things together, and you say, well, what infection can cause that? Geez, I don't know. So you try to think about an ingestion when you get symptoms like this. By inhibiting the Krebs cycle, you'll get a metabolic acidosis, and you can also have liver damage. Don't forget that it can cause coagulation problems, and it affects your platelets. Again, the presentation and the physical will vary according to the amount ingested. They can present with vomiting, hyperpnea, fever, lethargy, and mental confusion. Those are seen in mild intoxications. Seizures, coma, respiratory and cardiovascular collapse will be seen in severe ingestions. Hyperventilation, dehydration, bleeding disorders, seizures and coma will be seen in chronic ingestions. And don't forget tinnitus. And again, there are phases to aspirin ingestion. Phase 1, there will be a respiratory alkalosis, and you will be losing potassium and bicarb in the urine. That lasts about 12 hours, and you need to know these phases because it's a little bit different in children. We'll get to that in a second. The first stage or phase lasts about 12 hours in an adolescent, but may not be seen in a small child. And it can mimic diabetic ketoacidosis. The second phase, you get a paradoxical aciduria. That's about 12 to 24 hours after your ingestion in the adolescent, although it may be sooner in the younger child. And then the third phase is when you have your metabolic acidosis, you have dehydration and hypokalemia. It's a lot earlier in the infant. It occurs a little bit later in the adolescent. How can you diagnose an aspirin ingestion? Well, you have to suspect it. You can get levels in the blood. The white count, the hematocrit, and the platelets may all be increased, as well as your BUN and your creatinine. Again, you can see anything as far as labs are involved. You can have hypernatremia, but you can have hyper or hypokalemia depending on where you catch it, what phase. They can have hyper or hypoglycemia, so that's not very helpful, but you put it all together and it might help. And the arterial blood gas shows a metabolic acidosis with a respiratory compensation in children. That's important. In adolescents, it's a respiratory alkalosis alone. So make that distinction for your blood gas. Now, you do have in your notes a similar to the acetaminophen nomogram. There is a nomogram also for aspirin ingestion, and it tells you whether it's mild, moderate, or severe. You have that in your notes. There is no antidote, but at least it tells you how bad an ingestion it could be. There's another little test that you can do, and it's called the ferric chloride test. And what you do is you take a drop of urine and you put it on a little ferric chloride tablet, and if it changes color, the tablet, then you know that you have aspirin in your system. It doesn't tell you how much. It is purely qualitative, not quantitative. So if you took an aspirin 5 hours ago or 3 hours ago and then you took something else, it'll show up as a positive ferric chloride test even though your level may be very, very low. But it's just a quick test to know that there's aspirin in your system. The best thing is to get a blood level. Treatment is again supportive care, gastric decontamination if it's soon enough or within a certain amount of time. You may try to change the urine pH by giving bicarb IV. and in severe cases may go on to hemodialysis. Carbon monoxide. And this is like a classic question, this one, the presentation. A 5-year-old is brought to the emergency center for a first-time seizure. The child was previously well and has never had a seizure. The father states that the child was traveling cross-country in an older model vehicle when the seizure occurred. The child was sleeping on the floor of the vehicle, and there were 5 adults who were smoking tobacco at the time of the event. This happens. On physical examination, the child appears drowsy, but otherwise the physical exam is unremarkable, and the pulse ox reads 97 at this time. So carbon monoxide is colorless and it's odorless, and you can get it from a bad car. Not everybody is like in the movies that they drive the car into the garage and then close the door and leave the motor running and die because they want to commit suicide. Many times it's because it's seeping into the car or into the house from something. What you need to remember is that carbon monoxide will bind hemoglobin a lot better than, will bind to hemoglobin better than oxygen does. 250 times better. So it displaces it and you don't have oxygen circulating around to deliver to the tissue because you've got carboxyhemoglobin. You have a list there of the level of carbon monoxide or carboxyhemoglobin, basically, and what the symptoms are. So 0 to 10%, you may not have any symptoms. For goodness sake, smokers are probably walking around with 3 to 5% levels as their baseline. Okay? So 0 to 10%, you may not have any symptoms. 11 to 20% can produce headaches. 21 to 30 can produce worse headaches and some irritability. 31 to 40 will cause severe headache, lethargy, nausea, and vomiting. You don't really need to know so much the levels, but do know how you can see how the symptoms are getting worse. 41 to 50 will cause confusion, syncope, tachycardia, and tachypnea. 51 to 60 can cause coma and seizures. 61 to 70 can cause hypertension, respiratory failure. 70 and above can kill you. So you just need to know the worsening severity of symptoms with the increased levels. You can sometimes see what they call cherry red blood. Now, sometimes the skin looks funny, but when you draw blood gas and you get this cherry red blood, you go, wow, that looks pretty good. Then you get a blood gas and you get your results and it shows that your PO2 is lousy, and you should really suspect that even though the blood looked really bright red, that's not because of the oxygen carrying capacity. Okay? So look for cherry red blood and you get a level. You will see an acidosis on your blood gases. The treatment is going to be removing the patient from the source. So get the car fixed, or trade it in or something, get rid of it, or fix the house, remove them from that source. And a definitive, if they have high levels, you need to put them on 100% oxygen. In severe cases, hyperbaric oxygen is recommended. What happens when you go from 100%, when you go to 100% oxygen, the half-life goes from like 240 minutes to about 47 minutes. The half-life of carboxyhemoglobin. When you put them in hyperbaric, it goes to about 22 minutes. The half-life. So that's not as good a return on your investment, because when you put them in hyperbaric oxygen, then monitoring is different. You can't have any electrical stuff around, things like that, mechanical monitors. So 100% oxygen is the first thing you're going to do for that patient as basically an antidote. Caustics, acids and alkali. A 2-year-old presents to the emergency. Another thing about the carbon monoxide is sequelae can cause behavior changes, memory loss, possibly blindness, and it can be, even with just one exposure, you can have the whole spectrum of complications. It doesn't take a lot to mess them up. Caustics, acids and alkalis. A 2-year-old presents to the emergency center with his parents, who say that they found the patient drinking some Red Devil lye. The patient is crying profusely, and of note, on inspection of the mouth are blisters and burns. The patient is drooling. Now, most patients don't swallow a whole lot of these caustic things because they burn, but they will get some down, and they will have lesions in the mouth. Generally, they spit the stuff out as soon as they try it. Caustics include acids and alkalis, and you have examples of each one's there with their brand names, so you know that which is which. The acids will cause tissue necrosis, and the alkalis will cause a liquefaction necrosis. Both of them basically burn. And the burns are going to be worse with lower or higher pH. So pH less than 2, pH greater than 12, you'll have serious injuries. You can actually see burns in the mouth. You need to be very aware of airway problems, because if you have burns in the mouth, there may be, and a patient is drooling, the drooling is probably because of the burning down the esophagus and all, but you also have to worry about airway problems. So be very cognizant of airway breathing and circulation. So you may see the burning of the mucous membranes. They can drool. They may have esophageal strictures. And they can have scarring of the pylorus and have vomiting or delayed gastric emptying. They're really diagnostic tests. You just have to look at the patient and get a history. Some of these patients, the patients, you will do endoscopy and see burns on them. So the treatment should be, first of all, removing anything, flushing, getting it off the skin or out of the mouth, whatever, removing it, flushing it out. You do not want to induce vomiting in these patients, because it'll burn on the way up too. And you do not want to do gastric lavage, because when you're putting the NG tube down, you could perforate the esophagus. So you don't want to do that. Endoscopy should be done to see where the scarring is. The role of there's really no reason to use antibiotics, and the role of steroids is questionable. You can argue one way or the other. Cocaine. A 15-year-old is brought to the emergency center with dilated pupils, tachycardia, and chest pain. A classmate reports that she thinks she saw the patient snorting in the locker room. So cocaine can be taken various ways. It can be snorted. It can be smoked. You can do anything with it. Don't forget, cocaine is like a very potent vasoconstrictor, and that will explain why you get problems with the nasal septum if you're snorting it, because it's a very potent vasoconstrictor. Cocaine has a very short half-life, which can help if you get them over the initial problems. Then they'll do fine, because it has a short half-life. It'll be eliminated quickly. Cocaine gives a feeling of euphoria. They will have CNS stimulation. So that means that they can have restlessness, excitement, agitation. They can have later hypotension. They can have seizures, coma, respiratory depression. They can complain of chest pains. They can have myocardial injuries. They can have a perforated nasal septum from snorting because of the vasoconstriction and the ischemia. And you can do a urine drug screen and test for cocaine. You may see, if they're body packers and they're smuggling and they're swallowing the stuff, you may see on an abdominal film, you may see the packets. And you can really run into troubles when one of those packets bursts and then they're getting a huge dose and they're absorbing it, and that's when it really kills them. Treatment, again, is going to be supportive. There is no antidote. And since the half-life is short, if you generally get them over that first hump, they will do okay. Hypertension can occur, however. Chronic cocaine users can develop a cardiomyopathy. Hydrocarbons, that's another one that's common on the exam, hydrocarbon ingestions. A 2-year-old is brought to the pediatric emergency center because the patient ingested gasoline. The gasoline had been placed in a soda pop bottle to be used for the lawnmower. The patient does not appear to be in any respiratory distress, but wheezing is present in the right base. The main problem with hydrocarbons is not the ingestion, because it tastes lousy. They're not going to drink a lot of it. But the problem lies in aspiration. and then you can have an aspiration pneumonia. Okay? Hydrocarbons can be found in fuel, solvents, cleaners. The patient may have cough, emesis, and fever. Symptoms may be delayed for 6 hours. So, you just don't come into the emergency department, they listen to you, and you're clear and you go home. You have to observe them for 6 to 8 hours because they may have symptoms later on. On physical exam, you can find shortness of breath, wheezing, rales, dullness to percussion because they've aspirated. And on X-ray, you may see aspiration pneumonitis. The treatment is again supportive. Gastric lavage is contraindicated because the patient will probably cough and gag and aspirate. If it's a severe poisoning, you can do a gastric lavage. However, most patients just take a swig, they swallow, it's terrible, and they spit it out. So again, it's going to be supportive care. Antibiotics are not indicated. Complications are few. Usually they will recover. They can't have respiratory problems. Organophosphates. A young boy who is visiting his grandfather's farm is brought to the emergency center by ambulance. The grandfather says that the child had been playing in a newly fertilized field when he developed drooling, tearing, and emesis. At present, the patient is areflexive and has defecated and urinated in his trousers. The patient appears lethargic. So you're going to find organophosphates in insecticides. They are acetylcholinesterase inhibitors, and what you need to remember about them is what we call a hypersecretory state. Okay? And you have a list of symptoms and signs there, and I'm going to give it to you as a mnemonic. All right? And what's the mnemonic? Dumbbells. That's right. Oh, that's a lot of chocolate. Everybody knew that one, huh? Some people say sludge too, but the mnemonic is dumbbells with one L, right? Right. D-U-M-B-E-L-S. Okay? So the D is for diarrhea. The U is for urination. So it's hypersecretory, basically, right? What's the M? Meiosis. So they'll have pinpoint pupils. Bradycardia. The E is for emesis. It also is for edema. These patients can present in pulmonary edema. The L is for lacrimation, another secretion. And the S is for salivation, another secretion. Okay, so dumbbells. Also, there's a triad of bradycardia, meiosis, and fasciculations. So look for those three together also. And that's indicative of an organophosphate exposure. And usually you will have a history of the child being exposed to some insecticide like in the farm or things like that or in the house. Okay? So dumbbells, you got it? So you have those, and we don't have to go through all these symptoms here. What are your diagnostic tests? Well, basically it's going to give you a history and a physical. You may draw red blood cell cholinesterase activity, and it will be decreased, and that's your best test. However, that's going to take a while to come back, so you really need to suspect it and treat it. How do you treat them? Again, ABCs. If it was exposure through the skin, take their clothes off and wash the patient so you get this, that you will prevent it from being absorbed anymore. And you have two things that you can give, atropine or pralidoxime. Okay? Atropine is your best bet as your choice. Okay? There are some of the organophosphates are carbamate esters, and the pralidoxime will not work as well. So if you have to choose atropine. And you give atropine sometimes continuous infusions until you get a reversal of symptoms, till they start to dry up, till they get tachycardic, till their pupils get big, until their secretions slow down. And then you slowly wean that down as that stuff wears off. The next poisoning we'd like to talk about is iron poisoning. It's the most common cause of death from poisoning in childhood. And the severity depends, again, on the amount of elemental iron. Okay, there are some preparations that say so many milligrams, but you have to look most of the time in parentheses, and it'll tell you how much elemental iron is there. And that's the value you're looking for. It's also divided into stages. Stage 1 occurs about 30 minutes to 6 hours after the ingestion. The symptoms will be nausea, vomiting, diarrhea, and abdominal pain. It can actually mimic a hemorrhagic gastroenteritis. Right? The second stage occurs 6 to 12 hours after the ingestion. And again, similar to when we talked about acetaminophen, the patient clinically improves. So the first stage, they'll have symptoms. Look for hemorrhagic gastroenteritis. The second stage, they tend to get better. The third stage is 24 to 48 hours after the ingestion. If this happens, it indicates a more severe poisoning, and they'll have progressive circulatory collapse. They'll go into shock. They can have hepatorenal failure, bleeding, a metabolic acidosis, and they can actually slip into coma. The fourth stage is much later. It's 1 to 2 months after the ingestion, and this is when you have signs and symptoms of GI scarring and obstruction, and they can have vomiting similar to pyloric stenosis because of all the scarring. Okay. Now, you need to keep in mind that children's vitamins with iron do not have enough iron to cause iron intoxication. It's when the child gets into grandma's vitamins or mom's iron vitamins or whatever, and when you get into the adult preparations, that's when you have problems. So if you buy the regular over-the-counter vitamins with iron for children, that's not enough iron to cause problems. It's the adult preparations that cause the problems. You have to, again, get a good history, and you follow the symptoms to be suspicious for iron toxicity. A serum iron level can be obtained, and levels of greater than 500 is considered a severe poisoning. You sometimes can see iron tablets on an abdominal film because the actual iron tablets are radio-opaque. Now, if the baby, the child, got into the liquid preparation, then you won't see it. So iron tablets may be picked up on an abdominal film, but the liquid preparation will not. The treatment, if there's no gastroenteritis, you may use emesis if it's been within a reasonable amount of time. You can use whole bowel irrigation to flush out the tablets. If there's still tablets there, you may go with them with an endoscope. There is an antidote for iron toxicity or ingestions, and that is deferoxamine. Okay. Treatment is supportive, and you may use deferoxamine. Deferoxamine should be administered to patients who are symptomatic, patients who have hypotension and lethargy. If they have those symptoms, it doesn't matter what their levels are or what their total iron binding capacity is, you go ahead and give it. Otherwise, you wait for a serum iron greater than the total iron binding capacity. If the serum iron level is greater than 350, you can also use deferoxamine. And when you start them on deferoxamine, you will start seeing that the urine will change color to like a wine, vin rosé. I don't know what vintage though. Complications include the GI scarring and obstruction. A 24-month-old child has a lead level of 19 on a routine screening for a well child check. The patient is asymptomatic but lives in a historic home that is being renovated by the parents. So lead poisoning is a chronic disorder, often in children who are near environmental exposure risks, such as old houses that are being restored, or old houses where the children can eat the paint chips off the radiator, off the walls, things like that. Nowadays, houses, you use unleaded paint, so you don't have to worry about that. But in older homes where the paint was still leaded, as people who are renovating these homes, they're stripping off all those layers and they're getting into the deeper layers, and those are the ones that would have the lead. So then you have an aerosolized lead in your home as you're stripping off all those layers of the old paint. It can also occur in chips from pottery or lead plates and things like that. And sometimes fishing weights have lead in them. Okay? You know, lead glazed pottery, we talk about a great source of dietary iron is using cast iron skillets. Well, if you use lead glazed pottery, that's a great source of lead, although we don't want that as a dietary source. So there you have a bunch of a list again. Household dust, paint removal, contaminated soil and water will put you at risk for lead exposure. Pipes can cause lead poisoning, and some folk remedies, such as the lead glazed pottery. The majority of patients are picked up on routine screening. Since we do routine screening now, we will have patients before they are symptomatic. So most patients will not be symptomatic. Children are screened on a routine basis at certain ages, and that's how we pick up most of the cases. The majority of the cases are going to be urban as opposed to rural, but they're still going to be picked up on routine screening. Anorexia, apathy, lethargy, anemia, decreased play activity, aggressiveness, poor coordination, poor school performance. These things may be some symptoms that are picked up with lead intoxication. Chronic exposure will include apathy, clumsiness, nausea, and vomiting. Acute symptoms include apathy, nausea, and vomiting, progressing to coma and seizures. They've been ingesting actively, and it's a little faster. They can have encephalopathy if they've been actively ingesting. The test to diagnose lead poisoning is a blood lead level. So if they ask you which is the best test, you're going to get a blood lead level. Free erythrocyte protoporphyrin and all that other stuff is helpful. The best thing is a blood lead level. Okay? And levels greater than 10 are considered abnormal. So this child's at 19 already. CBC may reveal anemia. X-rays will show what we call the lead lines. What you see here on a peripheral smear is what they call basophilic stippling. Okay? So that's basophilic stippling that you'll see on a peripheral smear. There's the lead lines. Show you some more lead lines. Look at these. See right there? There. All along. Those are lead lines. And here, this is a patient who has actually been actively ingesting within the last couple of days. See all that stuff there? That's lead. So this is all lead from a patient that's been actively ingesting. So these are all corollary findings that you can see in a patient with lead poisoning. The treatment, first of all, you need to remove the child from the environment. If it's an asymptomatic child that you pick up on screening, you need to find out the source and remove them from that source. And you have a list in your notes of what you can do. Greater than 15 to 19,
level, you need to screen every 3 to 4 months. Greater than 20, you need to confirm it with a venous blood. If it's still greater than 20, you remove the lead source. Greater than 45, then you need to put them on medications. Okay? So 55 to 69 will be EDTA or Succimer. Succimer is an oral form that chelates and binds the lead. And greater than 70 will need EDTA and BAL, British antileukoside. If you're symptomatic, with high levels, you probably need both medications, EDTA and British antileukoside, BAL. Okay, so severe is going to be chelation. Moderate is consider chelation with oral medications, and mild is just remove them from the environment. Okay, and there you have encephalopathy can occur after 3 to 6 weeks of actively ingesting the lead. And usually it's a child less than 3 years of age. Antihistamines. A 2-year-old took his brother's allergy medication. He is brought to the hospital by ambulance because of tremors and hyperactivity. The medics report that the child had a seizure before arriving at the hospital. On physical exam, the patient has fever, flushed skin, tachycardia, and fixed dilated pupils. And these are just all the side effects of taking these antihistamines. Antihistamines are very common because everybody has them in the household for their allergies, to calm them down, for itch, things like that. So they're very common in many houses. They are many times over the counter. You don't need a prescription for them, so anybody can just go get them. So again, that's why they're so common in the household. And many times it's the child's own medication that they're taking. They can depress or stimulate the central nervous system. And some of these antihistamine preparations will also have some alcohol in them. So if they get enough of it, they might have a little bit of alcohol ingestion too. The presentation varies. Some patients will just be drowsy. Others can have insomnia or nervousness and restlessness. Some of the antihistamines are not just pure antihistamines. Like I said, they might have some alcohol in them. Some of them are antihistamine decongestant combinations, and so you have like pseudoephedrine, and that will hype them up too. They can be hyperactive and experience hallucinations, and they may actually present with seizures. They can have anticholinergic effects, so you will see the flushed skin, you can see the fever and the tachycardia and the dilated pupils. Again, there is no diagnostic test, and there is no antidote for antihistamines. It usually requires a high index of suspicion and supportive care. You can give activated charcoal, and if it's one of those long-acting antihistamines, those sustained release ones, then you can try cathartics or whole bowel irrigation. Barbiturates. A 3-year-old arrives with his parents after ingesting his brother's seizure medication, which happened to be phenobarbital. The patient has constricted pupils and appears to be in coma. So again, barbiturates are in a lot of houses because they are used as anticonvulsants. Usually that's the main reason they are in the home. They will enhance the GABA, and so they will depress the CNS. Mild to moderate toxicity will mimic alcohol intoxication. So they may have some, slurred speech. They may be a little clumsy. You can see those things. Severe acute intoxication will cause changes in level of consciousness and can cause respiratory depression. Look for constricted pupils, confusion, hypotension, poor coordination. They can have, again, respiratory depression and coma. Again, you give A, B, C's. Airway, breathing, and circulation. Take care of if they've lost their gag reflex, if they're having apneic episodes, if their level of consciousness is so depressed, you intubate them. If they're hypotensive, you may need to take care of that, giving them fluids. You can give gastric lavage and activated charcoal. Forced diuresis and alkalinization of the urine certainly helps with the long-acting barbiturates, and phenobarbital is a long-acting barbiturate. So you can alkalinize the urine here and charcoal, and that helps decrease the levels. Complications, well, you can die from respiratory arrest. Tricyclic antidepressants. A 3-year-old presents to the emergency center after taking her brother's bedwetting medicine. She is noted to be drowsy, and on the electrocardiogram, the patient has a widened QRS and prolonged QT and QTC. Cyclic antidepressants are in a lot of households too, and that's a very common ingestion. Many times it's the person who had the medicine prescribed to them. They're depressed. They're not taking. They figure they're going to kill themselves. They take their antidepressant medication because they've got a bunch of it. So it's very common to see tricyclic antidepressants. They will produce sedation. They will have alpha blocking effects, and they're anticholinergics. The main thing you have to look out for when you're reading your test question is what they mentioned there as far as the QRS and the QTC. So every patient that comes in with suspected tricyclic ingestion should have an electrocardiogram done. Now, you can check the levels, I mean not levels, you can check for it in the blood or in the urine, you can check for tricyclics, but part of the management is going to be getting an electrocardiogram and monitoring these patients. The 2 most common causes of death and complications will be cardiac arrhythmias and seizures. Okay, so you need to be looking for that in your test question. So they may present a child like this and they might ask, what do you have to watch out for? You have to watch out for arrhythmias and seizures. Other symptoms can include drowsiness, delirium, hallucinations, disorientation, seizures, and coma. Initially hypertension and later on hypotension. And remember your arrhythmias. So an electrocardiogram should be obtained on everybody, and they need monitoring. Supportive therapy is given. Activated charcoal can be used. Sodium bicarb is used to alkalinize and to prevent dysrhythmias, and you can treat the dysrhythmias with lidocaine, and you treat seizures with anticonvulsants. So basically there is no antidote. It's supportive care with special attention to the arrhythmias and the seizures. And finally, you have a table with particular medications and antidotes. So again, acetaminophen, we use N-acetylcysteine. For anticholinergics, we can use physostigmine. Anticholinesterases, we talked about atropine and pralidoxime. Carbon monoxide, oxygen. Cyanide, you do 2 things. You give amyl nitrate, and then you give sodium nitrite. Remember digoxin? Oh, and then a sodium thiosulfate too for cyanide. Digoxin. There is an antidote. The brand name is Digibind. It's the only time I use a brand name, I think. And it's fragments, the FAB fragments of digoxin, so it'll bind to that and inactivate it. For ethylene glycol, you use ethanol. Remember the heavy metals. We already mentioned iron. Opioids, naloxone. You need to remember that one. We kind of talked about it a little bit when we talked about resuscitation, but for opioids, use naloxone. Okay? All right. Let's go on to the next chapter now. Head trauma. A 5-year-old fell approximately 6 feet from a tree and is brought to the emergency center because he had loss of consciousness at the scene for 1 minute. The patient is awake and alert on arrival. His Glasgow Coma score is 15. The patient has an obvious deformity of his right forearm and some bruises. Otherwise, the physical exam is unremarkable. Okay? So you're going to get an x-ray of this child's arm. You find out it's broken, right? You're going to take care of that. What else are you going to do for this child? CT scan of the head, okay? Because there was loss of consciousness for a minute. We'll talk about that in a minute. Head trauma is a common cause of childhood hospitalization and even bigger numbers of visits to the emergency centers. Serious head trauma is usually secondary to, and these are in order, motor vehicle accidents, followed by sports, followed by recreation, and followed by violence. Okay? So now let's talk a minute about, before we move on with head trauma, let's talk about the car seat. So we said that you need to be in a car seat on your first ride home from the hospital, okay? And you need to be facing the rear, and the safest place is the back seat in the middle. You need to know that. At 1 year and 20 pounds, you can now turn the car seat to face forward. Okay, this isn't in your notes, but that's why you have room on the side. At 1 year and 20 pounds, the car seat can now turn forward. The safest place is still the back seat in the middle. When you are 4 years or 40 pounds, then you can graduate to what's known as the booster seat. By the time you're 7, at 7, you can then go to your regular seat belt. How many of you wear seat belts? How many of you ride in cars? This is New York. Everybody takes the subway. How many of you use seat belts? Not enough. Every hand should be up. Adults should wear seat belts. Okay? No child under the age of 13 should be in the front seat if you have a passenger side airbag. Short adults should not be in the front seat if you have a passenger side airbag. Okay? All right, that's my soapbox for cars. You better wear your seatbelts. Next, we talked about sports, recreation, and stuff as causing head trauma. Okay? How many of you ride bikes? Not too many of you. Come on, you got to get some exercise. How many of you bike riders wear bike helmets? Why not? Just one. Just one. Right over there? You wear a helmet? What was that? What did he say? No, you said that because you saw me with the chocolate. Because you didn't raise your hand when I said who wore a helmet. Because nobody said, oh, I'm not going to raise my hand. I'll be the only one. So you don't get any chocolates. You got to wear a helmet. Everybody should wear a helmet. There are about 200 deaths a year under the age of 16, and that's where they keep the data. So who ride bikes, get hit, fall, and die from head injuries. At least 200 deaths a year. Okay? Trampolines. Bad move. Okay? 55,000 injuries a year from trampolines. And that can be anything from twisting your ankle to breaking your neck. So that's why we're talking about it with head trauma. Okay? What? No, trampolines are not nice. They're dangerous. They're dangerous, all right? So wear your helmets. Don't go on a trampoline, and wear your seatbelts. Presentation of head injury depends on the trauma. A patient may present with neurologic deficit or without a neurologic deficit. Like this child presented with no deficit whatsoever at that time, but had loss of consciousness. Some patients will stabilize and others may deteriorate. That's pretty easy. Children with neurologic deficits may have had a history of a lucid interval and then relapse. And then you should suspect what? Epidurals. Very good. The physical exam varies according to the injury. Patients, here we have a list of various injuries, and I'll show you some things in a second. So the epidural, always look for the lucid interval. You don't have this table, but don't worry. The epidural, look for the lucid interval. So they get knocked down, they get up, and then later on, they go down again. And I'll show you in a second a CT scan with epidurals. Okay? And then you have acute subdurals, chronic subdurals. You can have intraparenchymal bleeds, subarachnoid bleeds, or just a contusion. Okay? And an epidural needs an evacuation. Subdurals probably do too. Chronic subdurals certainly do, depending on symptoms. Let me show you. I'll just get ahead of myself here a second. All right, so this is an epidural. An epidural hematoma. Look for what's known as lenticular or lens-shaped. Okay? So when you're reading the test question, if they're describing a CT scan that says lenticular or lens-shaped, you should suspect the epidural, especially with that lucid interval. A subdural will present with what's known as a crescent shape on CT scan. So rather than going in this way, it pretty much follows the outline of the cranium. So it'll be what they call crescent shape. It'll be kind of like that. Okay, so look for that key word when you're reading the question. Okay, so these are some of the things that you will find on physical exam. Patients can have depressed skull fractures or just linear fractures, skull fractures. This is what we call battle sign. Boy, people want chocolate here. Yeah, you said it. Gee. Oh, sorry. Okay, so that's battle sign, which is this ecchymosis around the mastoid. Okay, it's indicative of a basilar skull fracture. What's this? Hemotympanum, which is indicative of basilar skull fracture also. That's blood behind the eardrum. Sometimes you will have some discharge or clear drainage from the nose. Okay, that's not that they have allergies or a runny nose. That's cerebral spinal fluid after a head injury. Or they can have discharge drainage from the ear, and it could be cerebral spinal fluid. Okay? Now sometimes it'll be, if it's clear, you can check it you can do like a glucose on it, and it probably is cerebral spinal fluid. Sometimes it'll be mixed with blood. So if you do a glucose on it, it could be a blood sugar that you're getting. So you don't know the difference. So you do what's called the ring test, like a ring. And you take a piece of filter paper or a coffee filter, and you take a drop of the stuff that's coming out of the nose or the ear, which is mixed with blood, and you put that drop on the filter paper. And the blood will stay in the middle, and then you'll get this little yellowish ring around it. And that tells you that is cerebral spinal fluid. If it was pure blood, you just get a drop of blood. So that means that it's mixed with cerebral spinal fluid. So that stuff that's draining out of the nose or the ear mixed with blood is cerebral spinal fluid. So that's called the ring test. Okay, concussions. Some of the injuries. Concussion is the most common head injury seen in children. And usually it's a brief, loss of consciousness, and then they return to normal. You've seen a boxer get knocked out, that's a concussion. Okay, they come back a couple minutes later, most of them. Disturbances of vision and equilibrium can occur, and concussions are divided into different grades. And you need to know these because they may ask a question as to when can the child return to play sports. And we'll get to that in a second. So the grades of concussion is grade 1, where there is confusion, no amnesia, no loss of consciousness. Grade 1. Grade 2, confusion and amnesia. Means they don't remember what happened. No loss of consciousness. Grade 3, confusion, amnesia, and loss of consciousness. So all three are involved. Okay, so when can you send them back to play? And these are very recent recommendations. A patient with a grade 1 concussion, if they have no symptoms at that time, they can go back in 20 minutes. So you make them sit out for 20 minutes. A patient with a grade 2 concussion, if they are asymptomatic for a week, can return in a week. If they have a grade 3 concussion and they've been asymptomatic for a week, they can return in a month. So, Eric Lindros and Steve Young and all these guys, they have to follow these guidelines. Well, they should.
Okay, so grade 1 concussion, if you don't have any symptoms, you can go back in 20 minutes. If you had a grade 2 concussion, asymptomatic for a week, you can go back in a week. And if grade 3 concussion, if you've been asymptomatic for a week, you can go back for a month. Now, a second time grade 1 concussion, you can go back in 2 weeks after being asymptomatic for a week. A second time grade 2 concussion, you can go back 1 month after being asymptomatic for a week. However, if you keep getting repeated concussions, not a good thing to keep going back. Okay? So a grade 1, 3 grade 1s, 2 grade 2s, or 2 or more than, or 2 grade 3s, call it a season. Okay? Take your multi-million-dollar check and do some commercials. Well, if you're in high school, just take the rest of the season off and study. Okay? Because you keep getting these concussions, that's not good. Mild concussions are usually not associated with any sequelae. You can, if you get hit a little bit harder, you can have what they call retrograde and antegrade amnesia. So retrograde amnesia means you can't remember what happened. Antegrade amnesia means you can't form new memories. When we talk about amnesia, we're not talking soap opera amnesias, you know, where the lady forgets everything that ever happened to her, you know. This is, you just can't remember what happened. I was playing, and now I'm in the hospital. I don't know what happened. Okay? Antegrade amnesia means you can't form new memories, so that the doctor walks in, introduces themselves, and they say, you know, they check the patient. They come back 6 hours later, 12 hours later. Do you remember me? No, I don't. Okay, so that's an antegrade memory. They're not forming new memories. And again, the severity of the injury corresponds with the amount of amnesia that you have. And as they get better, then they start making memories again. Okay? So it's not soap opera amnesia. Some patients will develop post-concussion syndrome, which includes memory difficulties, dizziness, and depression. Okay, we talked about the epidural. We mentioned the epidural. So epidural hematoma is a rapidly accumulating hematoma between the dura and the cranium. Look for trauma, loss of consciousness, lucid period, and then it happens again. These are associated with lacerations of the middle meningeal artery, and you will see the lens-shaped hemorrhage. And the neurosurgeon will decide whether they need to evacuate it or not. Okay? Subdurals occur with tearing of bridging veins. Subdurals can occur from head trauma. Subdurals, when we get to child abuse, we talk about subdurals then too. Usually it's a bridging vein, although it can be a chronic thing. It can be caused by arterial lacerations though. But look for what's known as the crescent-shaped hemorrhage, and you will need to evacuate it surgically. Contusion is a bruising of the parenchyma of the brain. These are usually frontal and temporal lobes, and you will see what are known as punctate hemorrhages on a CT scan. So they're not between the brain, they actually are in the parenchyma, so they won't be between the brain and the cranium, they will be in the parenchyma itself. And usually it's observation for these patients. They can develop cerebral edema, they can have herniations if it's a severe enough injury, and you manage intracranial pressure problems with these patients. CT scans. They should be performed on a child who has a history of loss of consciousness for greater than a minute, or if there is a question of loss of consciousness. If nobody saw it happen, you can assume that it might have happened and you get a CT scan. Children with abnormal neurologic findings should have a CT scan. Patients who have a deteriorating neurologic status, you need a CT scan. And you should also remember cervical spine films and always keep the neck immobilized until you get them cleared. Treatment, again, A, B, C, airway, breathing, circulation. If there's actual bleeding, you try to control that. You take care of other injuries like this child's broken arm. Always worry about cervical spine injury, particularly if you see bruises on the back or on the neck.
or if the patient complains of back pain or pain radiating to the arm. Many surgeons will not remove the cervical spine collar even though it's been cleared by the radiologist until the patient can actually wakes up and tells them, I'm fine, it doesn't hurt. Then they'll take it out. Kind of hard to do with a 2-year-old, but in older children or in adults, that's what they'll do many times. Many patients with head trauma will have drowsiness after the injury, but usually they're easily aroused. They can complain of headaches and vomiting. If there's been like no loss of consciousness, if the patient's physical exam is okay, you can probably send them home. Headaches and vomiting for the first hours or so after the head injury is absolutely normal. But if it persists, then you probably should do a CT scan. You can have transient neurologic disturbances, which can last minutes to hours. They can cause occipital blindness. You can be confused. You can have malignant post-traumatic cerebral swelling. These are all things that can happen with head trauma. They can have seizures after head trauma. The child with worsening neurologic signs must be suspected of having a subarachnoid bleed or subdural bleeding. And recovery varies. Certainly, the longer you stay after a head injury, the longer you stay in an abnormal neurologic state or comatose, the worse the prognosis. Patients who recover faster do better. That's kind of intuitive. Okay, drownings. A 15-month-old was found with his head stuck in a bucket filled with cleaning agent. The mother says that she received a telephone call while mopping the floor. She was only speaking on the telephone for 5 minutes. This is very common. My first day of fellowship in critical care, I walked into the unit and an 18-month-old was being taken off life support, brain dead. And this is exactly what had happened. The mom was on the phone, answered the phone, and the baby was moving around and fell into the bucket and couldn't get back up and drowned and died. So they don't need a lot to drown in. Okay? Toddlers in particular are top heavy. Their center of gravity is higher, so they will fall forward head first a lot. If they fall forward like that into a bucket, they can't get back up, or into a toilet. So a lot of these things can occur in the house, so you have to be very careful. Drownings, really what we should call them is submersion injuries. Because technically a drowning is a submersion that results in asphyxia and death while submerged or within 1 day of the episode. If you survive the first 24 hours of the submersion and then you die, it's a near drowning, whether you die or not. If you survive the first 24 hours, it's called a near drowning. So really, they should be called submersion injuries, which can be classified into near drownings, death within the first 24 hours of submersion, drownings, death within the first 24 hours of submersion, or near drownings, which means you survive the first 24 hours. What happens afterwards doesn't matter. It's called a near drowning. It's just a statistical thing. Okay? So that's the definition for near drowning. Transport to a hospital not severe enough to result in death within the first 24 hours. You might die the next day or a week later, but it's still called a near drowning. Okay. Near drowning is the second most common cause of accidental death in children. The numbers are fairly stable. There are about 8,000 drownings a year in this country. And 40% of the victims are less than 4 years of age. So that's the unsupervised child. The majority of drownings occur in fresh water because not everybody has access to the ocean. So they drown in fresh water, in the pool or in a lake or in a bucket. Other people at risk are teenage males and adolescents because they can't die. And that's how they feel. And they have riskier behavior. They may be drinking when they're swimming or diving and things like that. Unsupervised toddlers, children with seizure disorders, and obviously if you're under the influence of drugs and alcohol when you go in the water. And here are some sites of drownings. The home is the most common. Swimming pools and wading pools, water slides, hot tubs. Again, my first night on call as a fellow in the critical care unit
They brought in like a 12 or 14-year-old girl who was in a hot tub with her friends, and they wanted to see who could stay underwater the longest. And she went underwater, and she got her hair caught in the jet, and she couldn't get back up. And even though they came and they cut her hair to get her out, she died. She was a near drowning. She did not die in the first day. She died a few days later. So a hot tub is also a common sight. Obviously, bathtubs, toilets, and buckets, washing machines, these are more for toddlers and children and younger children. Drainage ditches, lakes, rivers, streams, canals, all this is basically fresh water. Okay? We also classify drownings into wet and dry drownings. Wet drowning means, and this is the most common one, is that wet drownings is fluid is aspirated. Most drownings start out as dry drownings because you have a laryngospasm so that you don't aspirate. But if you stay underwater long enough, then eventually it relaxes. You have to gasp for a next breath of air, and the water comes in and you aspirate. So dry drownings and wet drownings. And under risk factors and etiology, we already went over those. Okay? 98% of drownings occur in fresh water. And the clinical presentation varies according to the circumstances. Children with brief submersions may be awake and alert on arrival. Others can be in cardiopulmonary arrest, so it's a whole spectrum of how they can present. Physical exam varies according to the presentation. You need to monitor the vital signs, assess their Glasgow Coma score. Freshwater versus saltwater drownings. Freshwater drownings may have more lung damage secondary to the hypotonic fluid, which flushes out or washes out the surfactant. Whereas saltwater drownings tend to have more pulmonary edema because you have more water coming in trying to dilute the salt there. But either way, it's a lot of lung damage. You should always get a chest x-ray. You should get blood gases. You may need to consider cervical injuries too on these patients. The treatment is basically supportive. Prevention is the most important thing you can do. Teach everybody to swim. Make sure that pools have self-locking doors, that their slats are such that children can't get in between them. You shouldn't leave balls on the pool in the water because to a toddler, I'm going to go get the ball, they fall into the pool. So prevention is the most important thing. Once it happens, treatment is supportive. You treat the respiratory status. Most of these patients, the lungs we can eventually fix. The main problem is hypoxia and ischemia to the brain, and we cannot fix that. So if it's severe enough, that's the problem, is the hypoxia, ischemia to the brain. Okay, so these patients protect the cervical spine. If they need ventilators, put them on the ventilator. Treat hypothermia, IV fluids, basically supportive care. Okay? And again, neurologic injury is the main cause of mortality and morbidity for these patients. Burns. A 2-year-old comes to the emergency center after being splashed with hot coffee that fell off the table when he pulled the tablecloth. He has first and second degree burns. Okay, you already did surgery, right? Yeah, so you went over burns. Okay, so things haven't changed much. Burns can occur from this spilling. Burns can occur from fire. Burns can also be electrical or chemical. You need to remember the different causes of burns. Particularly electrical burns, it goes in here, goes out there. It doesn't look like there's much of a burn, but there's a lot of tissue destruction underneath. So burns can occur different ways. Burns are the second leading cause of death in children. Scald burns are 85% of the burns in children less than 4 years of age, and the typical story is the child that pulls something off the stove. Abuse also, they get dunked into hot water, and they get burned. Remember your types of burns. Okay, remember, first degree is basically just erythema. It's like a sunburn. Second degree, blisters. Third degree, full thickness. And they're supposedly anesthetic. And you can actually have fourth degree, which is what? Down to the bone and carbonification. Okay? You need to know your calculation of the body surface area. Remember that the rule of nines is different in children. There's more surface, and it depends as you get older. So an infant versus a small child, older child, adolescent. The rule of 9 changes. So that the head in an infant is much a bigger proportion of the body surface area than in a 10-year-old, for example. Okay? So you need to remember your rule of nines. We'll talk about the rule of the palm, which can be used for burns less than 10%, in which the child's palm equals 1% of the body surface area. So you take the child's palm and you put it all over, and you go, okay, that's 7%. Okay? Remember your resuscitation formula. Usually it's the Parkland formula, and it's your body surface area burn. And remember that when you are calculating the body surface area burn for fluid resuscitation, you do not use first degree. It's second and third degree burns that are calculated in there. So an easy question to get caught on would be a child has 5% first degree, 5% second degree, and 10% third degree burns, and they ask you to calculate the fluid resuscitation fluids or the deficit. And if you base it on 20%, 5, 5, and 10, you'll be wrong. You base it on 15%. Okay? So you do not use first degree burns in calculating your deficit. So it's going to be body surface area times 4 cc's per kilo. That is your deficit. Don't forget your maintenance. Okay? And remember that the deficit times 0 is the time of the burn. So if the child, let's say you want to give half the deficit over the first 6 to 8 hours, if the child arrives without an IV and the burn occurred 2 hours ago, then you are already 2 hours behind. So you have to give it a little bit faster. So remember, time 0 is the time of the burn. Only second and third degrees are used in calculating for the Parkland formula. Don't forget maintenance. Don't forget analgesia. Okay? Burns hurt children just as much as they hurt adults. And children need relief from pain. They're not going to be turned into addicts. So remember analgesia. Also remember tetanus status, immunization status. Because a burn is considered a dirty wound. So you need possibly tetanus toxoid.